Good morning, everybody. Greg Champagne, Sheriff in St. Charles Parish, Louisiana, which is not Lake Charles, Louisiana. That's in the southwest near Texas. St. Charles is basically now a suburb of New Orleans, about 30 minutes from Bourbon Street, if you want to go there. After Senator Cassidy got elected, the junior senator from Louisiana recently, right after his election, I ran into him in the airport, and he referenced this conversation earlier. And he asked me, he said, Sheriff, he said, what is it I can do? He knew I was an officer in the National Sheriff's Association, active with the Louisiana Sheriffs. He says, Sheriff, what do sheriffs need? What can I do for you? And I'm sure he expected me to say that we need more guns, better ammunition, higher-powered tasers, faster police cars. And I think he was taken aback by the fact that that was not my answer. My answer was, you've got to help us do something about the exploding problem of mental health, mentally ill people in our jails. And he was taken aback, and since that time, we've continued to talk about it, and thank you for taking action. There's always a lot of talk, but we need action, as everybody said. One of the toughest things about following so many good speakers is that all the good stuff gets said. So I'm going to be editing my points on the fly, and so if I seem a little disjointed, it's because I am, but I'm editing. I don't want to be repetitive to what's already been said and just repeating a lot of statistics. And in preparing for this, I kind of felt like, in regard to the points that I wanted to make, I felt a little bit like a mosquito in a nudist colony. There were so many places to bite, I just didn't know where to go first. So we'll give it a shot. I want to start with a quote from Congressman Tim Murphy that he made to Human Rights Watch, an organization which I'm really not used to quoting, but they got the nail on the head. They hit the nail on the head in this topic. And he said, we have replaced the hospital bed with the jail cell, the homeless shelter, and the coffin. And that summarizes the points that I'm about to make to you. This country started out in the 1700s, and the way we dealt with our mentally ill in the early days of this republic, democracy, is that we put them in jails. That's the way we started, and that went on for decades. Until in the 1800s, it was realized that there must be a better way and that they weren't necessarily criminals because they were mentally ill, that we needed to put them in hospitals. So we undertook, in the United States, decades of building mental hospitals and gave them all kind of bad names like asylums and places like that, you know, culminating in, you know, the movie back in the 60s, I believe it was, you know, One Flew Over the Cuckoo's Nest, you know, with Jack Nicholson. And then it was decided in the 60s that we needed to deinstitutionalize our mentally ill from these asylums and these hospitals, and it was a laudable goal and still is. The only problem is we went back to what really worked before, putting them all back in jails in the 1700s, and that's obviously being facetious. According to the National Association of Counties, 1 in 5 adults in the United States experience a mental illness. More than half of them did not receive treatment in the past year. It is estimated that 64% of jail inmates in the United States have some degree of mental illness. And just going back to my experience as a prosecutor for 14 years and sheriff, I've seen the pattern over and over again. We see a person with mental ill. It starts out with a small crime, a disturbance that we might mistake as being drunk in public, or disturbing the peace, as we call it in Louisiana. And so, you know, they were arrested by the deputies who really, at that time, we never focused on mental illness being, you know, the problem that it is now, because there was more treatment then. And so they get arrested. They spend a couple of days in jail. You know, judge released them. They get out, and the behavior just escalates. And it's always more serious the next time, more serious, and ultimately ends up with some really bad crimes, like homicide. And truly, there's nothing we can do with some. I mean, when someone then kills 5 members of their family, there's really not a whole lot we can do at that point. They're going to be institutionalized, and they will be for a long time. But we've seen the pattern, the escalation of behavior, just because, and it's gotten worse. And I don't know why. It just seems that when I first took office as sheriff 20 years ago, going to state conferences, national conferences, there wasn't much discussion among sheriffs about the problem of mentally ill and incarcerated. But now, and for some reason, within the last 5 years, for reasons that I don't want to attempt to expound upon, it is always the topic of discussion right now. And in fact, it is probably one of our #1 points, the National Sheriff, one of our main legislative priorities is to do something about mentally ill in prisons. The funding for as hospitals close in state and local facilities, the funding burden is shifting from federal government to state government as they close these to your local county jails, county sheriffs. And when you think about it, I am one of a group of sheriffs, 3,080 in the United States now, that we are all pretty much facility managers for the largest mental hospital with the largest population of mentally ill in this country. I didn't go to law school to become a healthcare facility manager, nor did probably my fellow brothers and sisters sheriffs do the same thing either. But the sad reality is right now we are. There are more mentally ill in state and local prisons around the country than there are in mental hospitals. In fact, in 44 states, the largest population of mentally ill is in a jail in that state, much larger than the largest mental hospital in those 44 states. The bottom line is that prison and jail setting is not beneficial to citizens with mental illness. We are on a learning curve, and sheriffs, I believe, around the country are doing everything possible to provide psychiatrists, psychologists in our jails. I have a psychiatrist who works for me, actually, so he's actually a deputy in our jail. And so we now are providing mental health treatment. And it's mostly medication. It's not therapy and outpatient care that they really need. So anyway, I'm going to cut short because, again, I had more comments to make, but a lot of it has already been said. And I just can't overstate the problem that we're dealing with right now. We never dealt with mentally ill in our jail for years, but just in the last few years, it's a constant thing. I can go into some descriptions of the kind of things that happen. I have probably one of the most modern jail facilities in Louisiana, built in 2001. When we planned it, we went with architects and engineers to design it, to have a good medical unit with it, but the concept of treating large numbers or housing large numbers of mentally ill citizens really did not come up at that time. So there's also a physical component to our jails to where we use disciplinary segregation. We try not to use the word solitary confinement, but disciplinary segregation is a key factor in maintaining order and discipline in jails, at least for limited times. When prisoners misbehave, there have to be some consequences, certainly not abuse, but some consequences. And so I think in far too many jails in the country, disciplinary segregation or solitary confinement also then deteriorates the illness of those who are mentally ill, and it doesn't help. So we are doing the best we can, and I believe sheriffs around the country are dedicated to improving what we do for jails, but we're really, truly not equipped to do it. And we're doing the best we can, but it is just not a good situation. So I'm going to close. Thanks, Senator Cassidy, for pushing this issue, and we hope your bill can pass, and it can provide us some relief. And it's also a crime deterrent factor. I mean, if we can intervene at the right stage, we can stop the behavior from escalating from just public disturbances to public intoxication and things like that on up to more serious crimes, because there is always a pattern of escalation to more and more serious offenses. So it could be truly a crime reduction factor by better treatment. So thank you, and I'll close now and sit and wait for questions.
Good morning. My name is Peter Jacoby, and I'm practicing emergency physician at St. Mary's Hospital in Waterbury, Connecticut. Let me also go on record in thanking Senators Cassidy and Murphy for what they are doing here today and what they have done and what we hope to do. I'm proud to represent the American College of Emergency Physicians, which is about 35,000 strong across the United States. And this bill and this summit addresses something we've known about for years, because we've been dealing with this problem in emergency departments for decades now. I've been asked to comment on the price of inaction. Let me frame the problem from an emergency medicine viewpoint. Most people come to emergency departments for help during psychiatric crises emergencies, and more are coming than ever before. It is a crisis in the United States. Millions of people are in emergency departments because there are severe shortages of mental health resources in the United States. In one poll conducted by ACEP, the American College of Emergency Physicians, 9 out of 10 emergency physicians stated that they hold, or as we call it, board patients, psychiatric patients, in the emergency departments for anywhere between 24 and 72 hours. There are patients who have been held in emergency departments for up to 30 days. And the majority of those that are held for 30 days are the adolescents and the pediatrics, because there are less services for them than anyone else. Not to say that there are services for the adults, but those, when you hold a kid for 30 days in an emergency department, that's inhuman and cruel. In my own emergency department, I'll give you my experience 1 week ago tomorrow, when I went on to work on the floor on Friday morning at 6 a.m. in an emergency department of 32 beds, 21 were taken up by boarded patients with psychiatric emergencies. Now, how do you expect me to then see the heart attacks, the strokes, the minor sprains and strains, the chest pains, and anything else that come in when I'm boarding 21 patients because they have nowhere to go except the emergency department? So I understand the jail cells, but on a daily basis, we're rotating these patients through the emergency department system. The cost of inaction and this continual boarding of patients provides an undue burden on all hospitals in the United States. Our departments remain filled with psychiatric patients. And it's not only the department. A study conducted in 2012, and we've spoken a little bit about this, showed that nearly 40% of adults with severe mental illness, such as schizophrenia and bipolar disorder, received no treatment in the year prior. Among all adults with mental illness, and we've heard this, 60% went untreated. And we continue to cut the state budgets and the federal budgets, which make the numbers only increase, which increase the suicide rate, and increases the rate of people hurt by violence or neglect, and increases the burden on emergency departments. Because if you have no insurance and nowhere to go and no access to primary care, your access to primary care, psychiatric care, or any care in the world is through the emergency department. So the cost of inaction is incredibly big to the healthcare system of the United States. I'm only going to touch a quick note on what we can do because I know there'll be questions coming up. So what does ACEP say from our standpoint that should be done? Well, we have to increase outpatient capacity and support innovative community alternatives. We need crisis residential services. We need more mobile crisis services. Crisis residential services would allow us to discharge patients from the inpatient unit, as you so well said, into another area rather than back onto the street. So more respite homes and more residential services where we can continue treatment makes the job easier, as does a crisis interventional service, which can go to the home or the site and potentially decrease the problem before it gets to the emergency department. We need enhanced outpatient resources and expanded residential care. Unfortunately, we're going to have to somehow increase hospital inpatient services and inpatient capacity. In my own state in Connecticut, we continue to decrease them. And now they're thinking of decreasing the adolescent facility or closing it altogether. And I don't know what we're going to do when that happens. Because of my 21 patients last Friday on the floor, 5 of them were children or adolescents. And that's an incredible number. And they sit there in the same population of everyone else who is now interacting, and one little note here sends this one off here. We need to improve care coordination. We've heard about that since early this morning. Better case management, better speaking ability between the primary care provider, the emergency care provider, the psychiatric care provider. And lastly, we need some increased education on the whole pharmacology of what we are attempting to do. And from an emergency standpoint, the more we can do, the better it is, and the safer it becomes for all my doctors, my nurses, and my staff, because on a daily basis, there are a lot of violent acts occurring in emergency departments, and many of them, unfortunately, are patients with behavioral health issues and/or drug issues. But lastly, before closing, I come from the world of EMTALA. And for those who don't know that, it's the Emergency Medicine Treatment and Active Labor Act, now some 35, 40 years old. Started out as a great idea in the anti-dumping law. But what it's also become is an unfunded mandate. And as probably the best thing I heard this morning from Senators Murphy and Cassidy is that we're also going to get the funding, because we can come up with great ideas, but if we can't fund them, we're just saying, that's great, go do it. We need to find the money, push the insurance industry to put the money where they have to, and end this crisis to allow us to really treat Americans like we're supposed to. Thank you.
Thank you. Thank you. Thank you. Let's talk about money. One of the things advocates get all excited about is looking at jails and prisons and saying, okay, we can show that it costs more to keep a person in a jail or prison. We can do housing first. We can do an assertive community treatment team. We can do that for less and less money. And yet we find states and governments not buying into that because they look at like the Bexar County model and they say that's cost avoidance. How do you get your people, your local folks, to buy into that they want to spend money? Or we hear these reports like the Perryman study out of Texas says for every $7 you spend on treatment, or every $1 you spend on treatment, you'll save $7. So we see all these things and we go, well, why isn't everybody buying into this? We have the stepping up, you know, saying get everybody out of jails and prisons. So talk about money. What's the problem here? If it saves money, if we know CIT, if we know jail diversion, if we know mental courts save money, then why isn't everybody jumping on board? Here, take one.
In my correctional facility, and we like to use the term correctional facility, I hold about 500 inmates, and there's a combination of local pretrial inmates, which is about 150. We hold about 150 Department of Correction minimum security inmates, which we use for public works projects, and I also hold about 150 federal inmates, pretrial federal inmates. So my population is a short-term population. Local government, the parish or county and everywhere else but Louisiana, what we receive for each of these inmates is a per diem rate. Locally from the parish government and from the state, for the state inmates, it's $23 a day. Right now, there are proposals to cut that per diem at state because of budget issues in Louisiana. The federal government, the Marshal Service, loves us. We're their preferred facility in the Metro New Orleans area right now. We get about $50 a day. That's a big thing, which none of those amounts are what it truly costs to house any of these inmates. So anybody that tells you that sheriffs in Louisiana, they used to say that, well, sheriffs are making profit from inmates. That is not the case. If somebody could show us how to make a profit from that, I'm happy to listen, but that's not the case. So that's what we get. And with that, we've got to provide the food, the medicine, hire medical staff. I got 24-hour medical staff, as I indicated, doctor, psychiatrists, nurses around the clock. That's our budget that we get to do that. So as far as influx of money to provide all of this, there isn't any. I mean, I don't know if that answers your question, but we have to make do on these allowances that we get to hold each class of inmate.
Well, you know, I said to you earlier in the day mental illness is not sexy. I mean, hearts, that's sexy. And stroke work, that's sexy because you can really say, wow, look what we're doing. But it's very hard to say mental illness should be funded in the same way. First of all, it takes more time. And there's a real element of time, but we've got to find the way to do it. And we heard earlier, the money's in the system and there should be enough. We might have to add more, but we have to figure out a way to decrease the dual diagnoses of the diabetic with mental illness who can't control the diabetes, because in the long run, we save money. And not only do we save money, we save their limbs when they get their chronic ulcers and they don't have to go to amputations. So all that will save money in the long process. We just have to understand that.
One thing you were talking about earlier, too, is a shifting in priorities, that mental health often ends up on the bottom, and right now we're in the middle of an opioid crisis, and that all of a sudden is pushing emergency rooms and hospitals to focus more on that? Is that?
Well, I mean, we embrace the whole idea of not writing prescriptions. I mean, the American College of Emergency Physicians has stated, this is wonderful. The AMA has stated, we are in favor of not writing, prescriptions for 30, 40, 50, 60. Now, we reserve the right to at least say, if you show up and fractured your, ankle here on Friday afternoon, I've got to be able to take care of your pain. But as that crisis comes up and there's so much dual diagnoses, we've got to attack it as both. And I fear as the opioid prescriptions go down, and we've seen this already in certain cities, the heroin use is going up. So the harder it is now to get the opioids means they're flooding the market with heroin. So we've got to concentrate on both sides of that fence, because so much mental illness is exacerbated by the drug use.
We're going to open it up for questions. I have one other question for you, Doctor. When we sit down as advocates, hospitals usually aren't there, and yet they're such a key part of this. And hospitals seem to point the finger at insurance companies and say insurance companies should be paying for this. Who's going to end up paying for all this?
That's a very good question. And I will say to you, and I'll speak directly from my hospital. So in the state of Connecticut, we've just had, again, a decrease in Medicaid reimbursement. Now, to my hospital, that's $12 million over the year, so it's $1 million per month we've got to make up. And we've got to find the way to make that up. Well, how many unfunded mandates can we do, and how much care can we give away, and how much can we do before you say, well, mental illness is great, but I also have to do so many heart surgeries and so many X, and I have to be able to provide for stroke care in the emergency department and have everything going. And when you look at that, it is a lot of money.
It's a mix.
The money, though, think about it. In the United States, we have enough money to provide health care. It's just how it's distributed. And I will take back to the insurance industry and say, wait a minute, it's a publicly traded company. They really should be turning the money back into the United States and to the people and providing more health care.
Okay. Go ahead.
First of all, I thank Senator Chris Murphy and Senator Cassidy for bringing this long overdue bill in the Senate and organizing this summit, and definitely for the good food they have arranged from their own pockets. But this is actually not a comment, not a question, this is a comment actually. I know that there is a price to pay for inaction, but I also think if there is an action, there should be oversight and follow-up. I give an example. I am the secretary of Connecticut Psychiatric Society, and as a part of that, as a part of my job, I go to the meetings of different local committees. In one committee meeting, one person was talking about his experience as a psychiatrist, was talking about his experience about his clinic. So he has a clinic. Actually, they have a combined clinic of 6 doctors. 3 are internists and 3 are psychiatrists. This is an addiction clinic, and they accept people from with different addiction problem. The problem is here that the people, the patients who come to see the internal medicine doctors, they don't need any prior authorization. But the patients who come to see the psychiatrist in the same clinic, they will need prior authorizations. And this is from Medicare, Medicaid. So it's not only that they need for the first visit, they need prior authorization, but also for if one of the psychiatrists is covering the internal medicine doctor, the patients need prior authorization for coming to see him. This is, although we have this mental health act, Parity Act for last, 2008 through now 8 years. And in Connecticut, it has been there since 2000. So we still have this not properly oversight parity. So I think this should be corrected. In the same clinic, they have these patients who are coming on every week for drug treatment, but the insurance company allow them to have drug treatment only 8 times a year. Now, I don't think that any board, any addiction board will allow that the patient comes 8 times a year. Patients should come every week, and they should be tested for drug for every week. But the insurance company will not pay for this. So I think action is important, but at the same time, oversight of the action is also important. So we need to take care of that too.
Thank you very much. Debbie?
Hi, good afternoon. I'm Debbie Plotnick. I'm with Mental Health America, and I want to start by thanking Senators Cassidy and Murphy for looking at things in a comprehensive way. Today has been really wonderful. Your panels are wonderful. What is really, I'm hopeful, and want to speak to Pete's question about money, want to hear more about this, is that we're looking at things comprehensively in the bill, and yet when we talk about it in, we heard from pediatrics, we heard from primary care, we heard ways that we can attend to people earlier. Now we're looking at folks who are in late stages, in emergency, in corrections, and not having it. So the money issues have to be when we bring them together. One of the things that Mental Health America would very much like to see is a 10-year plan to end incarceration of people with mental health conditions who are not violent. And again, another place for money. But again, what we're seeing, and I'd like you guys who are the back-end guys to address about how looking at the front end would help you and dividing it out of there so that we're not caught in this false dichotomy of saying jails have become new hospitals. It's not jail or hospital. It's that whole continuum. So please make a comment.
Thank you very much. Did you have a question?
I did. I'm Jane Fitzgerald. I'm a private psychologist in Virginia now, but I used to work in the community mental health system, so I'm really familiar with the issues with prisons and people coming in and out of those and how deleterious that is. Back to what you said about the evidence that $1 spent on mental health is, saves $7. Is the problem that you can't get the $1? Is that what it boils down to?
Well, this would be a long question because there would be an argument that if you're spending $200 billion, that there should be adequate money there. It's just how it's applied. And you can look at California with the millionaire's tax, which raised over $1 billion, and yet they're still struggling to provide decent mental health services. So money is just part of the equation, I would say, but please, you guys want to jump in, jump in.
Take a switch. One of the things I would say to Debbie from Mental Health America, I think the upstream part is awareness, and I'm really grateful that part of this bill is the awareness both in high schools, middle schools, and campuses, because if there's a fear to even go seek treatment, if there's a lack of understanding that you need help. My parents didn't know that I needed help. They thought I was just stressed out when I was literally psychotic. So if there's an awareness that, listen, this is not normal, depression is not normal, you need help. I think that's the first key issue, and we have to start early. And the parents need to know as well, because I've speak in schools, and the kids want help. You go into a classroom, you talk about mental illness, and they're like, I need help. But parents are the ones that say, you just need to study harder. It's not your, so I think it's that awareness piece. That's the upstream part.
But back to your question on money. It is more complicated. One thing the bill does is it tries to make some sense of all this and better resources, where to spend those resources. But you not only have to know about the money, you have to know whose pocket's being picked. The sheriff has just told us how much he pays. If he shifts those people out of jail onto, I know in Virginia, the state would have to pick up the cost for community mental health care, so they have a disadvantage. They want the county to pay for that. So this is where you have to get everybody together and working together.
Well, I also asked the question, what costs more money? Having true respite homes or residential areas post-hospitalization, or sending the person back onto the street to go back into crisis, to go back into the emergency department, to go back into a 3-day hospitalization and back onto the...
$1
And these are
million
people brighter than I am. I mean, these are the economists and higher pay grades and whatever who can figure that out. But honestly, I have to think that the system, and I think this bill is addressing some of this need for coordination between the system. So we can build and develop some ways to not have that spin, which is just spending money and spending money and spending money and not getting anyone necessarily better.
Okay, I'm Glenn Chattel. I really didn't expect to give another comment, but Sheriff Champagne, this is very appropriate. There is a bill now. The Senate passed it in mid-December. The House Judiciary Committee passed it in mid-January, but it hasn't come up for a full vote in the House. It is called the Crime, The Crime Reduction and Mental Health Treatment Act. It reauthorizes and reforms the Mentally Ill Offender and Treatment Act, the previous bill. It is a very important bill to help prisoners, ex-prisoners. We really should do whatever we can to get it voted on. Speaker
Thank you.
Paul Ryan needs to get it on the floor.
Thank
as
you.
soon
You're
as
talking
possible.
about
All right.
Horns and Franken's bills, right? Did you have a question, or do you just want to mention the bills? Okay. go
And the
ahead.
National Sheriff's Association has, I think, weighed in support of that.
Yeah, Senator
that's-
Corn's bill.
Yeah,
Right.
and-
CIT, mental health
Senator
courts.
Franken, too, yeah.
Yeah. Go ahead.
Okay, thank you. My name is Dee Loftus. I'm working with substance abuse and mental health outpatient practice. And my question is, we're seeing a lot of folks throughout the gamut, from those that are very well-to-do to those that are coming back through the prison reentry system. One of the concerns that we have is that those coming specifically through prison reentry, although there is this cost savings and we're not seeing it translated into actual program planning, is we're seeing a real issue with the research says if they are having stable housing and stable jobs, they have better success with their long-term recovery.
Right.
Based on that, the programs are asked to increase their hours of service, so they're providing evening and weekend service. However, we have a huge obstacle to care. The majority of patients, especially those that are on medical assistance, do not have transportation or funds for transportation. Many of the states and counties and localities don't have the bus lines to service them. And so we have an access to care where there's a need for the care. Maybe they have a health insurance card to get the care, but they're not able to get there. Many programs, counties, states have transportation grants, but the cutoff hours are daytime hours. So we have a disincentive to providing them hours that would help them, based on the research, to have evening and weekend treatments that wouldn't interfere with their work schedule. So we're asking going forward that we look comprehensively at these access to care issues. And we feel that one of the best ways to do that is to have research-based through whether it's a public health or it's a Harvard or it's a Hopkins public health, but have some kind of database where we're getting a baseline and then looking at cost savings and what's being done in different, to learn from evidence-based practices what's being done in certain other areas that's been successful. Those clients that we do offer evening care to, and we have been able to arrange transportation for, we've seen dramatic success in a short period of time, and they're coming back telling us that it works. So we would like to see this opportunity expanded.
And just to comment on that, I think that's the power of having people who live the experience in this conversation, because who would know that, listen, I can't get to my services unless you talk to somebody that can't get to the services. Mm-hmm. So I think having one person at least have a voice who needs the care, who's seeking the care, who can't get the care, is part of the conversation. So I think that's why lived experience is so important.
No one's behind me, so I'll just take part two. We're also concerned about the dental access. Dental care, dental pain, untreated, those in high poverty, those that don't have dentists that take medical assistance in their area, are often then we're finding getting hooked on heroin and having difficulty coming off. So we would ask that we're not just looking at physical injuries, but that we also have screening tools that are pushed out there across the board to the public and the practitioners that include dental pain and access to care for those that are in poverty.
Thank you.
Thank you.
Thank you very much to the panel.
So we're going to have everybody go grab lunch. You've got box lunches around the corner. Get your lunch, come back, and then we will sit down and have a conversation with State Sen.